Okay, thank you all, everyone, for coming to today's presentation on psychological first aid. My name is Perlan, and I'm a student in the Human Services Department, and my concentration is on trauma and crisis counseling at Regent University. Today, we are going to talk about the Johns Hopkins Rapid Model. So if you look at your handouts, there are many different kinds of psychological first aid. But first, let's define what is psychological first aid. So again, I'd like to refer you to your handouts. Like you can see that we are aware of physical first aid, right? It's when there's an accident or someone has broken a bone, and then we apply physical first aid, using our first aid kits at home, something like that. So physical first aid is like the practice of medicine, and psychological first aid is the practice of psychotherapy. But don't feel intimidated because psychological first aid, just as physical first aid, can be administered by anyone, right? If we get the proper training, we don't have to be therapists. We can still help people to people suffering from psychological distress. So I specifically chose to talk about the Johns Hopkins Rapid Model because it is theoretically grounded, it's evidence informed, and evidence based. And it's also very simple and very easy to remember. So let's start. We have here a quote from the Minnesota Department of Health, and it says, "Emotional distress is not always as visible as a physical injury, but is just as painful and debilitating." So as we go through our presentation today, I want you to remember this. Because if you remember the Great East Japan earthquake in, in Tohoku on March 11th, 2011, there was a study conducted by some researchers, and they studied 241 evacuees in Fukushima. And 33% of those people indicated probable symptoms of PTSD. So we don't usually hear it on the news, they don't really talk a lot about it, just the physical damages. But just the same, emotional distress and psychological problems happen to these people, even if we don't know about it. They said that Japan is one of the best, how do you call that, prepared country in terms of disaster preparedness. And you probably know that I survived Fukushima. I was there, and I also evacuated. I was living in Fukushima City when the earthquake happened. And there's one thing that I realized. I realized that the disaster preparedness of Japan was not enough. But to be fair, it was a crazy triple disaster. So who could have prepared for it, right? But the point is, I feel like if we have the chance to prepare ourselves physically and mentally, we can be more resilient as a community when disasters strike. So let's move on. So on page 1 of your handout, you can see some explanations about the rapid model. And psychological first aid, as defined by this model, is a supportive and compassionate presence, and it is designed to stabilize and mitigate acute distress, as well as facilitate access to continued care. So I want you to remember these words because they are very important, okay? Supportive and compassionate presence, designed to stabilize and mitigate acute distress, as well as facilitate access to continued care. So, also in your handouts, you can see what psychological first aid is and what it is not. So, it does not entail diagnosis. Please remember that when we are giving psychological first aid, we do not diagnose people. We do not label them, and we do not treat them, especially if we are not mental health professionals. So the rest of the details are here in the handout. I will just skip that part and I'll let you go through that later. So here I'd like to talk about the goals of the RAPID model. So the first goal is to meet basic needs. This means that even though we are giving psychological first aid, we have to remember to meet basic needs first. So later we will talk about that more in details. Another goal is to stabilize acute psychological or behavioral reactions. So when I'm not sure how many of you have been in a crisis situation, or an evacuation center, but when you serve in a disaster response team, or when you do disaster relief, you will meet so many people with extreme behavioral reactions. They can be moderately distressed, depressed, they can be upset, angry, all sorts of emotions. So the goal of the PFA is to stabilize those emotions and behavioral reactions. So the next one is to mitigate acute distress, impairment, or dysfunction. And we do that in order to assist in the recovery of some degree of adaptive functionality. Okay? So the goal is to help them adapt to the situation and function. So this is just a little extra information. I think I mentioned a little bit about this during the morning meeting yesterday. Let's say 100 people suffered a big disaster, okay? Only 7 to 9% will experience post-traumatic disorder. Not everyone. So think about it. Only 7 to 9% will suffer PTSD. And then 14 to 15% of all the survivors or the victims will experience what we call PTG, or post-traumatic growth. So you will be surprised how human resiliency actually comes out even in the midst of a disaster. It's beautiful how people can be so resilient, and how they can even grow from that crisis, right? So let's remember this word, because this is very important: resilience. So the next one is to foster natural coping and resilience mechanisms. When we help people, we help them cope naturally. We don't give them lots of new advice or new goals. We listen to them, and then we find out how they can naturally cope. Okay, and last one is to facilitate access. This is typographical error. To facilitate access to continued support or higher level care. if necessary or indicated. So these are our goals in the rapid model. So rapid actually is not similar to, it doesn't mean fast. It's an acronym. That's why I chose this one, because it's easier to talk about and it's easier to remember. R stands for rapport and reflective listening. A, assessment. P, prioritization. I, intervention. And D, disposition. Okay, let's move on with the first one. R. So the primary foundation of rapport building is conveying an attentive presence. So this, everyone, is very important. Attentive presence, okay? And a willingness to listen. If you think you are not willing to listen, maybe giving psychological first aid may not be for you, because this listening is a big part of giving psychological first aid. So some people call it a ministry of presence. This is not in a religious sense, you know, not ministry in a religious meaning, but it means you're serving people, you're ministering to people through your presence. So you have to be attentive and you have to be very willing to listen. It could be upsetting. Usually it is upsetting. So, but you still have to have the willingness to listen. And the primary goal of reflective listening is to make the other person feel understood. I'm not sure if you have any ideas on what we can do to make the other person feel understood. Does anyone have an idea? What's one way to make the other person feel understood? Oh, yes. Please go ahead. I'm not good at katakana.
Maybe using open body language, or saying yes, or that sort of thing.
Thank you, Nick. Okay, now I recognize your voice. So thank you. That's exactly correct. We need to have good communication skills, and we are going to talk about this because this is very important. But first, we gotta show empathy. Why? I want you to look at this. Number one, empathy denotes understanding. And understanding leads to trust. And finally, trust fosters adherence. One very important thing we have to remember about survivors of disasters or big crises is that they lost their sense of safety and security. That means they're afraid to trust anything, okay? There's no more trust. Maybe not absolutely zero trust, but it has been damaged. Their sense of security has been damaged. And so we have to start by building on that, okay? How do they trust us? There is no instant trust, you know? People don't trust you instantly. But if you show empathy first, then it will convey that you understand them. And when you understand them, and when they feel that you understand them, then they can trust you. And when they trust you, then there's adherence. So we got to start with empathy. In counseling, in counseling, a guy named Carl Rogers, the father of humanistic psychology, he wrote a lot about how to be a good human being and how to use those characteristics in counseling. So the first one is empathic understanding, right? And the second one is unconditional positive regard. That means we accept those people as a person worthy of our time, worthy of our care, someone who is valuable. So we don't neglect anyone, whether they are really, really old and hard of hearing, or really, really tiny like a baby. They're all important. They're all valuable and they deserve unconditional positive regard. So these are the things, very basic, but very important. Okay. So this is an interesting one because people in the field of psychotherapy have been using like good communication skills to help people in distress, right? And recently, the New York PD, the New York Police Department, their hostage negotiation team came up with these uh, communication tactics in hostage negotiation situations. But when we look at it, they're the same as giving psychological first aid. Same skills, all right? Different situations. I hope you do not attempt to negotiate a hostage situation, but we can certainly remember these things to help people with psychological first aid. So the number one is you minimize distractions. When we want to establish rapport, when we want to give people a sense of safety, we have to minimize distractions. And then we introduce ourselves properly. Okay, I think you have it in your handout on page 6. I wrote here some examples of how you can calmly, politely introduce yourself. And so again, there's ensuring safety here because as I mentioned before, they lost a sense of safety. And so that's why we have to give it to them. Facilitating rapport by being respectful, direct. Direct meaning we don't elaborate so much, okay? We keep it simple. We have to be credible and honest. And we have to be aware of the way we speak, our volume, the pace, and the tone when we're speaking. And this is important also, adapting to the hostage taker's vocabulary. Okay, so it's not hostage taking that we're learning here, but you can see on page 6 of your handouts, there are different ways when you're talking to an adult or a caregiver, and there's another way when you're talking to an adolescent or a child. So we use their vocabulary. We adjust ourselves based on who we're talking to. And then of course we clarify. We want to understand what's going on. We have to clarify the situation. We have to get the information, correct information, and only then we can offer a solution to the problem. Okay, so let's move on. So we finished R, which is rapport and reflective listening. Now we are going to talk about assessment or listening to the story. So in every story, there are two elements, and we have to remember these two things. We have to listen for what happened, and we have to listen to the person's reactions to the event, okay? Now you gotta be careful with number 2. You don't wanna play the role of a therapist, and you don't wanna intrude, okay? Don't ask too much questions or too much details. Just remember not to intrude and allow the person, the survivor, to tell you what happened based on their perspective. So once we listen to them, we need to remember two processes of assessment. First one is called screening. So screening is the first step of assessment. So these are just yes or no questions, very simple. One thing that trauma does to our brain is it disconnects the neural pathways, so that we don't have enough language to explain what happened. So this is very helpful because usually people who suffered trauma, they can't elaborate. So we don't push them to elaborate. We don't intrude. We just ask them simple questions, yes or no questions, like that. So that's number one, screening. And number two, another process of assessment is appraisal. Okay, maybe these two words sound so difficult. So here's an illustration. So for screening questions, it could be something like this. All right. You don't ask the person, but you ask yourself, is there any evidence that this person needs assistance? If the answer is yes, you proceed. If the answer is no, you move on. Why? Because in the event of a big disaster or crisis situation, chances are there are many people in need of help. And we got to identify who needs help and who are good on their own. So these are the first three questions that you have to keep in mind. Okay. Number two is, can they function? If the survivor is a mother with a little kid, can the mother take care of her kids, like that? Okay. Or are they going to be compromised? So we just evaluate, screen very quickly, yes or no. And number three is there further exploration into this person's capacity for adaptive mental and behavioral functioning warranted? Do they need to talk to a professional counselor or a psychiatrist? Yes or no? Easy screening questions. So the next one is the appraisal questions. Once we finish that, we have to ask ourselves, to what extent, right? To what extent? On pages 7 to 9, I listed some things for you here to refer later on how we can assess the extent that this person needs assistance. So for example, if you look at your handouts on page 7, you can see two boxes. One is distress. Distress means mild psychological distress. Of course, we expect them to be distressed, although not all of them, but the point of this appraisal questions is to clearly identify whether the people are suffering distress or dysfunction. Is it a psychological distress or a psychological dysfunction? So let's use page 9 as an example. In your handout, there's a spiritual assessment. When we hear people questioning their faith, they say something, or in there like questioning their faith or questioning God's actions. Why did God let it happen like that? So it's more common for people to say things like that during disaster. So that's mild. That could be the distress. We're in a dysfunction is when they just shut off like everything about God, or they go to a different extreme wherein they want people to be ultra spiritual or ultra religious. And it could be a negative religious coping, which is a topic for, another day. But I hope you understand the difference between mild, moderate, and severe cases. What I've given you on the handouts are just some examples. It's not a complete list, but just to give you some ideas. So the next one is P, prioritization. Okay, so this is the psychological triage. Now, in medical term, when you go to hospitals, when they assess you, what are you feeling right now? Not every patient who goes to the hospital goes to the emergency room, right? So some, they ask you to wait. Some, the doctor see you immediately. Some of them go straight to the emergency room. So same thing in the psychological situation. So as someone who's giving PFA, we need to prioritize people according to their relative urgency of need for psychological first aid and psychosocial support. So we determine the recipients when there are more than current resources to attend to. For example, here on page 10, you have people who need special attention and support. So when we go to an evacuation center, for example, we look around and see if there are people with serious or life-threatening injuries, and if they need emergency medical care, right? So we should prioritize. What are the signs and symptoms? Are they mildly distressed, or moderately distressed, or severely dysfunctional? So we have to listen carefully. So that's the assessment stage, so that we can perform the triage properly. Okay, and what their specific needs are. So what determines urgency of need for PFA or psychosocial intervention? Number one, if you remember Maslow's hierarchy of needs, medical and psychological needs always comes first, okay? If people are injured, we need to get them to stability. If they are starving, we need to give them food and water. And then number two is physical safety and other physical needs, such as shelter, give them blankets, things like that. And number three is behavioral and psychosocial needs. Okay, so here we look at the people and try to observe if they can handle childcare, based on their behaviors. Can they handle childcare? Can they take care of their old parents? Can they go to work? If you notice that they haven't been taking care of themselves, like physically. So we need to look at all these things and try to help them meet these needs. Okay, so we are not going to dwell so much on this because this is a very heavy topic. Some predictors of PTSD and dysfunction. I included the list just for your reference, but maybe if we have some other time to really study about this, that would be great. But for now, let's skip that one, because I want to show you another triage model, which is called ABC. Okay, so these are groups of people. Group A, important, and urgent. So these people are highly impaired, dysfunctional, and suffering psychologically and physically. And they are mostly in need of PFA and perhaps other types of support, such as medical support, things like that. Now, group B is important, not urgent, or urgent, but not important. So what does that mean? Some people are resilient in the wake of adversity, whether we believe it or not. Like some people are, they can still function, right? They can handle even after they lost everything to the tsunami or something like that. They experience increased distress, which is common and normal. But most survivors will be in this category. So you remember what I mentioned earlier, that 7 to 9% of survivors develops PTSD. They're the most vulnerable group. They're the A group in this model. And then the rest is the B group, okay? Like most survivors are in the B group. They can still function. Yes, they experience distress, but they can still function. And C is neither important nor urgent. So these are the people who are likely to experience post-traumatic growth after a disaster. They are functional and, if not often, heroic. Like I have heard so many stories of people in the middle of a disaster. They're the ones saving their neighbors, saving their neighbors' dogs and things like that. So that's group C. And I in our rapid acronym refers to intervention tactics. So what can we do to stabilize and mitigate acute distress? So we have here, we can meet basic medical and physical needs, or just cathartic ventilation. What does this mean? We have to be, remember the ministry of presence? Sometimes some people just needed someone to talk to, someone to listen to them, and they express their emotions, and we just got to be there to sit with them. Sometimes we just don't say anything, or like Nick said, we can show our interest using our body language, and we can nod, we can say in counseling we call that minimal encouragers, just to let them know that we are listening to them. We can give guidance, and sometimes distraction is good. I learned that distraction is particularly good in children, young survivors. We give them a task, we play with them, we talk to them, and this is more of a stabilization technique. So we use it to stabilize their emotions and distress. So I have listed some things also in the handout, but other things we can do is to just cognitive reframing. So if they're thinking if there's a distorted thinking, we can correct that, or some illogical thinking. So remember, when people are in the middle of a disaster, they are very confused. All right. So sometimes they just think that everything is a catastrophe, something like that. So we have to help them reframe. It takes training and experience, and I hope we get the chance someday to have a proper training, and so we can practice these things. We can teach them stress management techniques. And this is very important. We can instill hope, not all is lost, not all is gone. but we have to be careful how we convey it, how we say it. There are proper ways, and I think I have given you some tips in the handout. So here we have a faith-based intervention. Uh, Religious coping has been proven to be really effective. So we can also use that as Christians, especially if we are ministering to other Christians as well. Yep, when in doubt, ask what the person needs most right now. If you're still clueless, it's like, I'm sure this person needs help, but I don't know what kind of help. You can ask, what can I do for you right now? Or what do you need most right now? And yeah, you have to be very, very careful because, like I said, we don't have to disrupt the person's natural trajectory of resilience. As I mentioned before, people are naturally resilient. So we got to be careful not to like treat them like babies, you know what I mean? We do not just do everything for them, because in fact it is good for them to do things for themselves and for other survivors. It's a very good thing. Finally is disposition and facilitating access to continued care. So this is the last step. This is when you summarize the main points of the interaction you just had with the person. Normally, PFAs are done only in a one-time basis, in a one day. You know, you volunteer one day, you talk to people, and normally the people giving PFA, most of them are volunteers, and they're only available for that specific day, and that's okay. That's okay. So if we know how to summarize the main points of the interaction we just had with people, that's enough. You probably have questions about this later, and we can talk about it more later. But let's just look at the rest of these right now. Ask the person how they are feeling right now. Yes, just to check in with them. Make sure you understand what they are actually feeling, right? Empathy and genuine kind of empathy. So make plan for the next steps. So where do we go from here? After this conversation, I need help. So what can you do to help me? You know, delineate specific steps necessary. We have to be clear, remember, from the communication skills, we have to be clear and direct. So tactically facilitate access to another level of care if necessary. Like I said, if you see that they are having panic attacks, palpitations, and, you know, maybe take them to a doctor, or in the evacuation center, or maybe let them speak with a health or medical professional. Or if they are psychologically distressed, severely distressed, maybe they can talk to a mental health professional in the field, right? Some people make plans to follow up, but that is if you are still going to be there. Remember, they lost their sense of security. And so that's one thing that we have to restore and make sure that they get, is a sense of security, that even if you leave, someone is still going to be there to help them. Yeah, we got to make that clear to them. Try to offer some realistic words of hope and encouragement. Do not lie. If we don't know any information, we got to be honest that we don't know, but we're going to try to find out for them. So that is the rapid method: rapport and reflective listening, assessment, prioritization, intervention, disposition. And finally, I also included a bonus because we need to help ourselves first. We cannot relieve the suffering of others if we ourselves are suffering. Okay. I know many therapists are wounded healers, but at the same time, we also take care of ourselves, right? You know, none of us are perfect, but we also need some level of self-care. And here are some tips on pages 14 and 15 for you. And maybe we don't have time for that. And